Cindy, Cindy Shu. Cindy and I did a Crit Care Fellowship back at University of Maryland Shock Trauma Center back. It's got to be what, almost 10 years ago now?
I know it's scary. How
It's
tough
so
that.
scary. She was my my senior fellow when I started. Currently, she's done very well for herself. She's the division chief of critical care for the Department of Emergency Medicine and an associate professor for emergency medicine and surgery at Michigan Medicine, where she cares for critically ill patients in the Emergency Critical Care Center, the EC3, the Adult Emergency Department, and the Trauma Burn ICU. She's got an MD and PhD from BU School of Medicine. She did emergency medicine residency at the University of Pennsylvania and trauma and surgical critical care fellowship at R. Adams Cowley Shock Trauma Center. She has a master's degree in clinical trial design and statistical analysis from the University of Michigan School of Public Health, and she is among the first in her specialty to hold dual board certifications in emergency medicine and surgical critical care. Her mission is to transform cardiac arrest care by bridging the gap between translational research and clinical implementation, with research spanning from large animal models to clinical trials that focus on innovative approaches to improve neurologic outcome after cardiac arrest. As a site lead investigator for cardiac arrest trials such as AROCA and ICECAP, and co-investigator for the Sirens Clinical Coordination Center, Dr. Su has maintained continuous NIH funding since 2016, including an NINDS R6133 innovation grant to nurture initial translational effects. She also served on the International Liaison Committee for Resuscitation Advanced Life Support Task Force and the American Heart Association's Emergency Cardiovascular Care Science Subcommittee, while championing emergency care and research equity as a RAND Center to advance racial equality policy, visiting health equity fellow, and leader of the Siren Diversity, Equity, and Inclusion Working Group. Her contributions have been recognized through accolades including the Society for Academic Emergency Medicine Early Investigator Award and the AHA Resuscitation Science Symposium Young Investigator Award. Ben was very upset that he has a meeting and can't make it today. He told me that he wanted me to send his best and wants a copy to watch the lecture later, but he was very sad when he saw that you were talking.
Yeah, Benabella was one of my mentors at Penn, and is now
Yeah,
so.
we got very lucky to have stolen him.
Okay, well, thank you so much, Evan. I'm gonna attempt to share my slide. Okay, let me know which version you're seeing.
You gotta flip it.
Okay, let me flip. How about now?
Still now it's perfect. Thank you.
Okay, there's a little bit of light. Okay, great. Well, thank you so much, Evan. It's been a pleasure and honor to see you virtually. We're just saying that like time flew, and it's before we knew it, was 10 years passed since we finished fellowship at Shock Trauma. So I'm going to talk about the title is Reimagining Critical Care Delivery in Emergency Medicine. And for those of you who practice mostly inpatient setting, I'm going to try to appeal to you how this is really intimately related to both the patients that you take care of, but also ultimately their outcome. And certainly it takes really a village to take care of critically ill patients that we see in our hospitals. So these are disclosures. I'm going to focus on predominantly critical care delivery models in the US. And there's going to be opinions that I'm going to try to interject, and those are my opinions. So the three key objectives, I'm going to provide a little bit brief history of critical care. And then the bulk of the talk is going to focus on the different critical care delivery models that exist within emergency department or adjacent in the US. And then I'm going to spend a little time at the end talking about some potential future state for our patients. So the origin of ICU is actually was from Florence Nightingale in the Crimean War, where she decided to really co-localize the sickest patients closest to the nursing station. And that was really the first iteration of intensive care, where we've tried to dedicate the most resources to the sickest patients during this war. Follow that, the polio epidemic in Copenhagen, where Dr. Ibsen set up the first ICU by providing positive ventilation with tracheostomy and iron lung in the Brigham Hospital in the 1950s. And it was actually the medical students who provided essentially hand ventilated these patients through the tracheostomy tube. There are essentially three founding fathers for critical care, which you guys all know, Doctors Max Harry Weil Shoemaker, and Peter Saffer. Dr. Saffer started the first ICU in the US at the Baltimore City Hospital. Essentially, this is the first physician-staffed ICU in the US. Dr. Weil and his fellow cardiologist, Dr. Herbert Schuben, established the shock ward at the LA County, which is essentially a unique ICU space where patients could be looked after 24/7. And then finally, Dr. Wells Shoemaker on the surgical side instituted and directed the first trauma service at the Cook County Hospital in Chicago. So that provides a little bit of a context in terms of the evolution and progression of how we take care of sick patients. I'm going to now focus on critical illness in the emergency department. So we know that critical illnesses are time sensitive. The therapeutic windows for most of our diseases that we care a lot about range from minutes to hours. And so time is really the window here. We also know that ICU admissions from the ED have doubled in the past decade, and probably even more now since the pandemic. So essentially, it went from 1.2 to 2.2 million in the first decade of the century. And the admission rate from the ED has also essentially doubled, went from around 1% to now over 2%. And about a third of ICU admissions spend greater than 6 hours in the ED. We know also that ED boarding is associated with worse outcome for ICU patients. You can see this is a summary of the relevant papers showing the odds ratios for death and the time of essentially ED boarding. So there's this ED to ICU transition where geographically the patient start in the ED, and then at some point it's deemed that they need ICU level care, and hopefully they can get transitioned to the ICU where the ICU team can start taking care of them. However, there's oftentimes this period of no man's land where we know they're sick and they need more intensive care, but either the bed is not available upstairs or the team cannot come down to take care of patients. And so we end up, the patients end up really languishing as more patients start to come in the ED. And so there's this question like, how do we provide really the critical care that these sick patients need while they need it the most and it's most sensitive? There's intersections, so this kind of brings into the intersections of emergency medicine and critical care, or what we essentially are calling emergency critical care, where we try to address this very time-sensitive and vulnerable space for patients' illnesses. There's now 4 different fellowship pathways after emergency medicine residency, where we can get board certification to really expand our capabilities of taking critical care patients through different pathways. You guys, and I personally went through the surgical critical care pathway, same thing like Evan, but I'm really glad to see that every year seems to be more and more programs accepting EM graduates. Okay, so now I'm going to pivot and focus a little bit about critical care delivery and the different models in the ED. So Dr. Saffer said in the 70s, we have defined critical care medicine as the triad of resuscitation, emergency care for life-threatening conditions, and intensive care, which includes all components of emergency and critical care medicine delivery system, pre-hospital and hospital. So this concept of, care at the right place at the right time is really important and relevant to impacting the outcomes of our patients. Just want to get a shout out to Evan. So this is a paper that he spearheaded during fellowship, which gave an overview, a really nice overview of the different resuscitation care units that existed at that time. So I'm going to actually provide a brief overview about each of the units, and actually add a fourth one, which is the Flex ICU at Cincinnati, which is the newest one to start last year. I'm going to start with our own shop, Emergency Critical Care Center, or EC3, at University of Michigan. So the driving force for EC3 in 2020 12 was that, as with all many different places in the country, we have seen a steady increase of ED volumes with aging populations, with sicker patients. Our ED to ICU admissions have increased by at least double the volume. And the hours that we're spending delivering critical care in the ED have also increased. Ultimately, what we found at Michigan was that during the years around that time period, our ICU admissions have increased to almost 3% overall, about 5 to 6 patients per day, and the ED length of stay for these patients were 6 hours. And so there was projected of 10% annual growth at that point. So, and that's really the impetus for EC3. The guiding principle was to create an infrastructure system necessary to provide time-sensitive diagnosis, monitoring, and treatment of critically ill and injured patients presenting to the university adult ED for now and in the future. So we wanted to take this very traditional gated silos of critical care at the quaternary center, which is each of the ICUs provide their own care and the ED does so, and then send the patients to the ICU to this more integrated system of emergency critical care. So the unit actually opened 10 years ago, on February 16, 2015, we just celebrated our 10th anniversary. And it has 5 resuscitation bays and 9 ICU beds. And the patient workflow is such that the patients will come through to the emergency department either through triage by EMS transfer or ED transfer. They will start either in the ED treatment rooms or in the resus space for the really sick patients. And then the initial ED team will provide the initial hours or so of care. And then when it's deemed that they need continued ICU care, critical care, then they will get transferred to EC3 for continuum of the care. And from there on, we either the patients end up going to a therapeutic option, so like OR, endoscopy, IR, or to another inpatient ICU if they continue to be really sick, or they can get downgraded to floor level care, or they can even get discharged. And so the staffing model is 24 hours attending presence with 1 to 2 providers that are APP or resident or fellows. And then we have 2 to 1 nursing, and then also ancillary support, RT, or pharmacy and laboratory. This is the number of people that work through EC3, so it's really a significant amount. We also have a Beagle here who comes through every Wednesday to help us. So this is really, it takes a village. And I would just want to say that also it's important to note that because the care starts the pre-hospital and then the ED setting, that it's really the entire department that's really important for the impact of EC3. Just want to play a quick video. Hopefully the sound would work. Let me know if you're not hearing anything.
The Emergency Critical Care Center, or the EC3, was designed to provide our critical care patients with continuous and seamless high-quality critical care right from the beginning. We were intentional about incorporating a lead-based design process into the design, really from the earliest stages. Unlike other facilities, the build of EC3 was confined to the renovation of the existing space. This was pretty challenging, in the fact it had to be built while we're running a busy emergency department. We saw over 80,000 patients last year. It is in operation 24 hours a day, 7 days a week. The design process really began in quite a unique way. We could have certainly just done blueprints or designed it on a computer, as it's traditionally done. We decided to make a full-size mock-up of the space, both the resuscitation bays and the individual patient care rooms, complete with labels on the walls, floor and ceiling, designating equipment, patient beds, and family space within each room. This allowed us really to make some real-time changes. Our design team could even been seen making changes to the blueprints right within the space. We knew we needed the expertise of all the disciplines that make up our hospital system and our emergency care team. Our design team is made up of physicians, residents, nurses, technicians, facilities personnel, clerks, biomedical engineering, of course the architects, the interior designers, our social workers, engineers, environmental services, and care management. About every job family you can think of that a patient would encounter during their stay. Our design team then walked through the rooms, brought in mock patients on gurneys, and recorded their changes and suggestions on the whiteboards throughout the mock-up space. We then were able to take their feedback and changes back to the architecture team to redesign, make sure the space was just what we needed to provide the best patient care possible. This lean-based design method allowed for changes to be made before the actual structure was built. Perhaps best of all, we empowered our staff. By incorporating all of our job units on the design team, they were invested in designing a space that they would actually work in. It was really designed to be a unique space to provide high quality critical care to our sickest patients. We now have 89 beds in the emergency department, which includes 5 newly redesigned resuscitation bays and 9 dedicated critical care rooms.
The EMS entrance flows right into our resuscitation bays. Each resuscitation bay is equipped with a power boom and large monitors designed for 360-degree care around the patient. The monitors allow for the entire room of providers to see information on the patient at once. Each bay is also equipped with cameras to record patient care for quality assurance and team education. We provide dedicated teaching space within the resuscitation bays by installing digital whiteboards, which double as patient care monitors and allow for real-time education. Right outside of the resuscitation bays, a shelving unit was designed to hold infrequently used life-saving equipment that staff needs to have immediate access to in an emergency situation. Sliding glass doors offer staff the option of closing off space for crowd control, noise, temperature control, and isolation. Should a massive casualty incident take place, the doors can all be opened to allow one large patient care bay. From our resuscitation bays, there is a seamless transition into our emergency critical care center, offering our staff the ability to provide longitudinal critical care to our patients, continuing from the resuscitation bays into the EC3 and upstairs into the OR or general hospital. Each room was designed with the head of the bed clear from equipment to be sure nothing gets in the way of patient care.
To improve patient safety, we tried to centralize the nursing station, provider station, where we could all communicate together and also see across the entire area. The lab was centralized within the unit with double-sided access from the resuscitation bays and the EC3 rooms to allow for sample drop-off from both sides of the unit. We changed the standard design of our transaction counters and raised them higher to allow for cart storage under the counters. We worked with a group of lean coaches who helped us to take the product that we had ordered from a furniture vendor and really coordinate it so that it worked well for our space and for our use. Storage was designed with clear and visible drawers and shelves to ensure staff is not digging through solid drawers looking for supplies. Each room includes an electric bariatric lift to facilitate patient movement instead of causing physical harm to staff trying to move the patient on their own. Patient rooms were designed with natural light instead of the usual fluorescent lighting to help with healing. Artwork adds comfort for patients instead of stark white walls. We sacrificed designing more rooms to design bigger rooms with more space for everyone. The new rooms are larger than code requirements and provide space on one side for the caregiver and plenty of space on the other side for the patient's family or visitors. And most importantly, our new rooms provide comfort and privacy for our patients and their family members.
All right. So hopefully that gave you guys some idea about just the physical layout and the design of the unit. I'm just gonna see if I can advance this. Here we go. So as I mentioned, EC3 has been open for 10 years now, and we've cared for over 20,000 patients since then. And we admit basically we're able to downgrade about 60% of patients from ICU level care to general care status. We end up admitting about a third of patients who continue to require ICU level care to an inpatient unit. We've been able to discharge about 8% of the patients actually directly home. Either these could be DKA patients or asthmatic patients that we treated and got better and they can go home directly, or some actually gets discharged to home hospice. And then we have about 2% of patients that we are able to provide dignified end-of-life care with their family in the space. So this is sort of specifically what the numbers look like, about 5 to 7 patients a day, about 30% who are mechanically ventilated, we see through EC3, about 15% on vasopressors. The average length of stay for ICU admissions have been about 8 to 12 hours, and then the length of stay for the non-ICU admissions have been about 12 to 24 hours. So this first paper was our white paper that demonstrated EC3 was associated with lower 30-day mortality and patient ICU admission. And we showed that about 3 lives are able to be saved for every 1,000 ED visits. The next paper, we demonstrated that EC3 was indeed cost-effective and improves the value of care by essentially maintaining the pre and post inflation-adjusted cost per ED encounter, with 7% increase in inflation-adjusted net revenue per encounter and about 50% increase in inflation-adjusted direct margins per encounter. The patients that we see include these diagnoses, so you can take a look. Very common presentation to the ED. And our special skills, we can provide mechanical support, intermittent hemodialysis, leukapheresis, plasmapheresis, bronchoscopy, endoscopy, and EVD. We've created a number of EC3 pathway order sets, and the list seems to increase every year, which we're trying to drive, standardize and protocolize best practice ICU level care for our patients. We published a number of different papers now on the impact of EC3, demonstrating both, as I mentioned, decreasing mortality and ICU utilization by both reducing short ICU admissions and also impacting things like safe extubation rate by able to extubate patients to EC3, also shortening the time to ICU care, as well as being able to discharge critically ill patients directly from EC3. And furthermore, we've been able to demonstrate the improvement in quality of care, including end-of-life care and avoiding hospitalization for these patients, as well as now actually most recently having to also care for the decompensated boarding patients because of the overall health system capacity issues. We live at the intersection of our tripartite missions, both by providing clinical care, but also in research and education, as demonstrated here. We have 2 fellowships, emergency critical care fellowships, but one through internal medicine pathway and the other one through anesthesia critical care pathways. We also, our faculty have been really instrumental in initiating and spearheading the critical care education initiatives for our EM residents. And we are able to use the space and our resources and faculty and nurses to be able to conduct innovative research studies. And this one was EROCA trial, which is a ECPR feasibility study, randomizing patients, out of hospital cardiac arrest patients to rapid transfer versus standard care at the scene, and then to get considered for ECMO cannulation in the ED. We are involved as a Siren clinical trial network, as both as a clinical coordinating center, but also as a site. Some of the studies we participated included IceCap and post-IceCap, and also C3PO, which is the COVID convalescent plasma study. And then we have the Weill Institute of Critical Care Research and Innovation, which is essentially, really support our faculty across the entire university on transforming critical care through innovation, integration, and entrepreneurship. And we've been able to leverage the EC3 space and patients to be able to conduct some observational studies especially for device and analytics proof of concept studies. We have been engaged in really globally with different health systems on to really help them develop their ED critical care delivery models in their ED. So that was EC3. I'm going to pivot a little bit and talk about other institutions who have different models of ED critical care delivery within their ED. So the next one is Stony Brook Resuscitation and Acute Critical Care Unit, or RAC. And this is a 3 resuscitation bay and 3 critical care beds with 16 high acuity beds, total 25 beds unit. So compared to EC3, the rack is actually more of a push model, which is that the patients who meet the criteria to go into the unit will get placed in the unit directly rather than going through the ED team. And I see about 2,500 patients per year and 4,000 high acuity patients per year. And the staffing is 1 attending with 2 to 3 residents or APP, and the rest of the staff is listed here. And so, as I mentioned, the patients can come through directly through ED or transfers from outside EDs. And then they place ESI levels 1, 2, and some 3s from the triage directly into the unit. And this is the special skills. So they can do ECMO, EVD, leukapheresis, bronchoscopy, and endoscopy, and SLED. So now the next one is CCRU, or Critical Care Resuscitation Unit, which has a special place in my heart and also in Evan's heart, I bet. This is a Shock Trauma Center. And this is an inpatient ICU model. 6 inpatient ICU rooms, about 1,500 or so patients per year, maybe even more now, I would say. They accept transfers from outside hospital, 4 upgrades, and ED admissions. The diagnosis initially started more of a surgical patients, has since expanded to really, multidisciplinary critical care patients from transfers or ED. So 1 attending, 1 APP, maybe with a resident or fellow staffing model with 1-to-1 or 2-to-1 nursing. And they could do ECMO, Reboa, CRT, Mars, balloon pumps. And so the first paper that got published during the tail end of my fellowship actually was the first year outcome, where they demonstrated a 65% increase of transfers of critically ill patients, surgical patients, and they were able to significantly reduce the median time to patient arrival from essentially half that, from 223 minutes down to 118 minutes, reduce the time to OR, and then also reduce their median hospital length of stay. There was a statistically non-significant trend toward lower mortality. And then since then, they published a 5-year experience from the CCRU, and where they continue to see significant increase in inter-hospital transfers that they were able to accept through CCRU. The CCRU received about 20% of all transfers per year at their hospital, with their median length of transfer time to the CCRU was significantly much lower than transfer time to the other ICUs. And then the most commonly accepted services were cardiac surgery, neurosurgery, and emergency general surgery. And then the newest kid in the block is the Flex ICU at the University of Cincinnati. And this unit opened last October. This year's Dr. Jordan Bonmo, the division chief and director of the unit. It's a 12-bed ICU, inpatient ICU status that specializes in the critical care needs of patients within the first essentially 1 to 3 days of illness. Jordan was able to share the first month's data with us. So they accepted 128 patients during the first month, about 70% from the ED, 20% from transfers, and then also 10% or so from inpatient transfers. Specialties from all over, medicine, surgical, neurological, and cardiac, and donor care even. And their dispositions looks like about 70% will get downgraded to general care or step down, 10% gets transferred to another ICU, 10% goes home, and then there's a 10% other category. Okay, so I think the units I've talked about thus far actually has a physical unit. They have ICU beds for, ED ICU beds to care for the patients. Now I'm going to pivot a little bit and talk about some different models of critical care consult service that can exist within the ED. I'm going to talk about 3 services: Stanford, Henry Ford, and University of Vermont. So the Sanford ECC service or program, it basically was started by a group of EM critical care faculty. They wanted to target the peak hours of ED volume. So essentially it's 2 p.m. to midnight on the weekdays. And what they do is, this is the structure of their team. So the patients will come through the ED, they get seen by the cared for by the ED team, and those who need ICU level of care will the ECC team will get consulted, and they provide care directly in the ED. And then from there on, they can either admit the patients to themselves, or they can admit them to upstairs, or they can admit the patient to another service. And they are generally residents or fellows can rotate through the service with ECC. They published their outcomes paper a couple years ago, basically demonstrating that with the difference analysis showing a 6% decrease in in-hospital mortality, and also a trend of decrease in ED downgrades for less than 6 hours. They actually saw that when I looked at the patient cohort that benefited the most, it looked like actually it was the patient with the intermediate severity of illness, which demonstrated a 12% decrease in mortality and almost 9% increase in the ED downgrade for less than 6 hours. At Henry Ford, they created an early intervention team, or EIT. And Henry Ford is a very busy academic center. And ultimately, what they historically, their high critically ill patients, ESIs 1s and 2s, ED patients get triaged to their Cat 1 area, which is 2 recess bay and 16 ICU capable beds. And then where the ED team will basically provide care for these sick patients. So what they've done is to create the EIT service, which is that the patients who have ongoing ICU level care can get consulted. The EIT team can help take care of these patients, basically. So, and these patients can either get admitted to the ICU, or if they're boarding in the ICU and the ED continue, the EIT team continue to care for them, basically. So these are the criteria. So if there's presence of 2 or more ICU boarding patients in the ED, and the patients on pressors, anatros, or advanced mechanical ventilation support, where they have planned ICU admission, or they're boarding for an ICU bed, then EIT can get consulted. And during their first 6 months, they reported about 5 consults per week. And then with self-reporting, average time per patient about 60 minutes. And they saw an increase in number of consults, essentially double from their inception, the first year, 2018, to the subsequent years. And then the last one, I'm actually very excited to hear more about in upcoming years, is University of Vermont Critical Care Transition Service. And so Vermont has, this was created in 2022. Vermont has 1 tertiary care center, quaternary center, 2 community hospitals, and then 3, I think now more, critical care access hospitals. And because of their catchment area, they also run into, the scarcity of ICU beds at the tertiary care center. And then also really essentially just with the throughput issues, patients end up staying in the ICU for a very long time. So what they did was created their EM critical care faculty, created a service to help support at the tertiary centers. They serve the ED and hospital wards, and they offer critical care consults and support to patients who are outside of the ICU, who needs ICU level of care. They also offer procedural assistance to the patients outside of the ICU. And then for their community hospitals and critical care access hospitals, they provide peer-to-peer support for their emergency physicians via telehealth. So more to come on that from the Vermont folks. Just want to give you a plug. So if you're going to SAEM conference in Philadelphia in May, there is going to be a panel discussion organized and led by Dr. Jeff Prakash from Henry Ford, and Ben Basson from Michigan, Mitari from Stanford, and Dr. Baker from Vermont will be talking about everybody's experience at their different units and models. Okay, and then one last thing about telehealth is this is probably the biggest paper that has come out from about telehealth critical care support and the ED. This is published by folks in Chicago at Advocate Christ. Basically demonstrated that for their any patients who require medical ICU admission who've been boarding for greater than 2 hours, they start enroll them into ICU telemonitoring. This is done in a retrospective kind of review process. And they looked at their outcome and they found that ultimately for the patients who did receive ICU telehealth support, who are waiting and boarding in ED, they had significant reduced mortality with odds ratios of 0.08 compared to those who didn't. So I think this is definitely, and certainly the Vermont team has started to incorporate this into their consult service. So more to come on this strategy. Okay, so just my last portion of my talk, I'm going to talk a little bit about future state, and hopefully we'll have some time for questions and comments. So the way I think about this is there are these kind of categories of opportunities that I would love for us to collectively think about as emergency medicine physicians and intensivists, is how do we really improve the early disease detection and prediction? How do we shorten the time to therapy? How do we be more precise about how we care for the patients through perhaps precision phenotyping and using some technology such as extended reality for sustainable training and for patient and family-centered care. And then certainly the last portion is how do we take better care of ourselves, which is through rest and wellness, and then diversification of ideas, fundings, and workforce. So there's a lot that is going on in the wearable technology space. And this has to do with, are there ways that we can actually detect the vulnerable patients and patients at high risk for deterioration, and how do we detect the onset of critical illness in general? So there's, we got watches, rings, all sorts of things that are in line and people are working on. So I think every year I'm reading about something new, certainly in the cardiac arrest space. And so I think more to come on this. The other thing is on the analytics side, which is leveraging just huge amount of hemodynamic data and just EHR data that exists within the health system. And this is something that our folks have created called AHI. It's an analytic prediction platform using just single ECG leads to be able to predict deterioration of in-hospital patients. And I think there's some exciting opportunities there to be able to use it on ED patients to predict, especially with a significant amount of boarding, to predict who might need earlier level of critical care. And then there is, in terms of shortening time to therapy, so for cardiac arrest space, which is the thing that I care a lot about, we think a lot about how do we initiate lay rescue interventions such as bystander CPR, AED applications, and even delivering them the things that they need AED through drones. And how do we promote that community to empower the community to be able to act when somebody collapses in front of them? There are certainly ways to bring therapies to the patient. In this case, ECMO, so for cardiac arrest patients, bringing ECPR to them. And people have done this through different ways. So in Minnesota, Dr. Yiannopoulos' team have actually built this whole truck, and they are now going to the different satellite hospitals to cannulate patients. In Paris, the group there have actually done it really all around the city. This is a picture of them cannulating somebody at their subway station. And then elsewhere in Europe and the Netherlands, pre-hospital helicopter teams are going out to the field to put people on ECMO. So different approaches and strategies have been started. The other way to perhaps bring the care that patients need, particularly in the rural area, is to develop multi-purpose care delivering platforms. And this is the paradigm funding opportunity, which was started by ARPA-H. I'm really just praying that the money doesn't get taken away. But the whole premise of this funding mechanism was to create and build a scalable, mobile, essentially multi-purpose vehicle to deliver care, advanced care outside of the hospital wall. And this is, they're targeting specifically the patients in the rural area. So trying to develop advanced imaging technologies that are portable, different ways to perform, for example, hemodialysis and screening and interventions and so forth. Slide is frozen a little bit. Okay, and then one quick note on precision medicine or precision phenotyping is that I think ultimately we would love to go towards something that's more like cancer research, what cancer research has done for their field, right? This is a schematic, a figure from this paper that I just show, where they demonstrated how to conceptualize this using patients with pancreatitis, where we would be able to leverage the different sampling data points, both on this could be essentially from EHR, biospecimens, hemodynamic data, and based on the time of the sampling to then create a high resolution by using machine learning and AI technology to then better characterize them and stratify them into different physiologic state of interest. And ideally create point of care testing and biomarkers to then be able to really stratify patients based on their physiology, the time of their critical illness, and then treat them accordingly based on their particular phenotype. And ideally in a very time-sensitive manner. So a few things about using technology to sustain our workforce and training. So certainly a lot of interest has been in extended reality space. And so this is a very good review paper kind of looking at how XR and VR could actually enhance both clinical care and training, but also on the patient and their family side to be able to actually help them go through basically recover from critical illness during the time of their hospitalization and also the time after that from recovery. This is, again, I think just kind of highlighting some of the opportunities there, different times of critical illnesses, critical patients, time course. And then I think procedural training is something that I think many of us think about is how do we, especially for what we consider as high acuity, low occurrence or low frequency procedures. How do we train our trainees, but also how do we sustain and maintain our own skill set? And I think there's a lot of opportunities here to develop using XR technology. This is just one example of using essentially an eyepiece and the HoloLens and to train through ECMO circuit and sort of team dynamic in terms of troubleshooting when the circuit has alarms going on. And this is an opportunity in the operating room even to be able to leverage augmented reality to predict and kind of guide the surgeon the next steps. And this is a picture of Dr. Sarah Murthy, who's a mentor of my ultrasound mentor at the Shock Trauma Center, who has been able to use augmented reality in the ultrasound space to be able to essentially not have to look at any monitors to perform ultrasound and be able to do this with somebody at another site, such as resource limited settings, to be able to teach them and also help them provide patient care with ultrasound. And then lastly, about post-ICU syndrome. So I think there's a lot that will be focused on during patients' hospitalization, but perhaps not enough during their recovery time. And I think certainly for cardiac arrest patients, many of them will come back, the survivors and their families will come back and say, we got discharged from the hospital and we don't know what to do. You know, our doctors don't know what to do. I have all sorts of questions. What do I do? What do I do next? And I think there's a lot of certainly trying to pair the survivors and co-survivors by creating a community and network for each other, but also pairing them with the right specialists who understand the different types of critical illness. And then just another kind of way to think about this, thinking about barriers to follow up on the patient's level, financial level, and environmental and societal level. Okay, and then I think ultimately, as I mentioned, can we actually think about how to, better ways to bring care to patients? So we're now talking about leaving the ICUs completely and providing care, either the pre-hospital setting or a patient's home even, or be able to find the patients who are at the highest risk of decompensating. And then lastly, about physician burnout, I think that this does not, we don't talk about this enough, which is ultimately that being able to provide the right care, the right time, the right place for our patients, it's not easy. And ultimately it requires somebody to be on 24/7 and to really take care of a lot of times very sick patients or very difficult positions. And how do we support ourselves? And I think that there are definitely opportunities to be able to leverage some of the technologies that I mentioned, but also like thinking about, are there better staffing models even? Are there better ways to design our space to be able to allow us to decompress and rest when we need it the most? And I think lastly, I think this is from my last couple of years of travel, is the importance of learning from each other within the US, but also globally around the world. I think each different hospitals have perhaps different needs and different problems, but there's a lot of shared interest and also shared knowledge that we can adapt by learning from each other. So just wanted to put a plug there I think it's another great way to really visit different places and make some friends. And so wanted to kind of mention that at the end of my talk. So again, thank you very much to Evan for inviting me. It's been a pleasure. I'd love to hear if you have any questions, happy to take them, or any thoughts or comments about this topic.
Cindy, that was a great talk. It was great to hear all that you've accomplished since Maryland. I'd be happy to open up the Zoom to anyone who has questions.
Yeah, one of the questions I have is, how is it funded and how do you get the funding? Because to have special unit, especially mobile units, is not cheap. So
Yeah.
and right now the cost of care just keeps escalating. So how do you do that?
Yeah, no, I think that's a great question. That's something that every place we go to, people ask about. So for EC3, we were fortunate to be able to have the initial philanthropy money from the Massey family, Donna Massey was a patient who had suffered from traumatic brain injury and had received her care at the University of Michigan, and they had started a foundation, and they really wanted to impact the initial golden hours of patients with TBI, but also critical illness. And so part of that was using some of their donated fund to actually create the EC3 space. But I think it's important that when we talk about costs, to think about how it would impact at the health system level. So I think with EC3, when you look at it on the paper in terms of the amount of resources it takes to staff the unit, it's pretty substantial, right? But when we start thinking about the downstream effect that it has on the health system, which is decreasing lengths of stay and being able to allow more transfer patients to come in, and things like that, then it becomes, I think that's actually one strategy that you can leverage to your health system leadership. Now, not every single place needs an actual physical unit, nor do they have the space, right? So I think that, and that's why I talked about the different consult models at Stanford and Vermont and Henry Ford, which is that they decided to create more of a consult or even telehealth model, which is that they can still provide the care to the patients as in the format of a service or telehealth, but not have to put the investment in to build additional space. And I think the pre-hospital setting is actually something that is very complex, because not a lot of some of the pre-hospital care does not get billed. And this is something that I talked to my EMS division chief, Tina Brent, a lot about, which is like essentially our paramedics and pre-hospital team provide a lot of great care, and a lot of times actually end up saving ED visits and ED admissions, but they don't necessarily bill for it, and that's actually a policy level. So I think it's very complex to in terms of like, but I think ultimately is the key thing is how do we deliver the best care in a timely fashion, and I think sometimes it does take multiple different strategies to make that argument to whoever is paying the bill. So
Cindy, along those lines, we were
Yeah.
talking about like whenever you have this conversation with leadership about building units like this, how do you justify or how do you show those kind of things that are not directly on the budget line, like increasing the admissions of the high acuity, the
Yeah.
surgery patients, the strokes,
Mhm.
neurosurgery patients? How do you show that to them to show that these units, while they might not make money directly, these things that are harder to quantify?
I think I cannot emphasize enough the importance of having very robust data analytic, and that is not just on the ED-ICU or ED side, but it's actually in the entire hospital health system. And so on our end, I would just be honest, like we have not keep track of our inpatient transfer data has not been really tracked for, especially for critical care requirement patients, and why we decline certain transfers have not been tracked as granular as I like. And that's something we're trying to address, right? So I think it's important to collect that data and then have friends, also make friends at the different, it's important to when you are trying to build something like this or create something like this to have stakeholders and partners on the inpatient side and hopefully on the health system leadership side as well.
Dr. Stu, what a beautiful talk. And it's so exciting to see all this innovation going on in the interface between ED and critical care, which has been a focus of lots of researchers, even at Mount Sinai. But I want to go back just for a second. You showed the picture of Dr. Bill Schumacher, and he was, along with Chris Brian Brown, the founder director of the surgical ICU at Mount Sinai Hospital in 1960.
And it's funny. I feel like we were just talking about finishing fellowship in 10 years, but there's a lot of people who don't know who Sapper was or Shoemaker was. Dr. Scalia talked about Shoemaker all the time, when we were at shock trauma, and so.
And Peter Stafford, I don't know how many people know this, but he was the original ABCs of resuscitation. In fact, his book was called ABCs. And in 1964, in one of the circles of resuscitation, one of his circles was hypothermia in 1964. And then in 2002, in the editorial which accompanied the first two randomized controlled trials, 40 years later, he wrote that editorial. So he did this without RCTs and then commented on the RCTs which appeared 40 years later. And that was a great Peter Stafford.
Thank you for that.
Yeah, hi there. Again, great talk, and I think this is something which, a lot of hospitals are struggling with. Only questions I had was, did you find, that having, this ICU and the ED decrease the overall time to patients going to like the ICUs, since they could be quote unquote cared for down there in the ED, number one. And number two, I also saw in some of your slides, I don't know whether it was the same, your model, but I saw some of them had in-hospital patients coming to that unit as well, which I found, interesting. Yeah, and the third comment I had was just the criteria for admission to the units, because I saw that just a small proportion of them actually end up in ICUs, and whether it would be better to have a unit whereby once you admit to an ICU, then you go there as opposed to once you're still in the triage phase.
Yeah, no, those are great questions. So your first question about, so the difference, I want to say the difference between EC3 and CCRU and also Flex ICU is we are still housed within the emergency department, and so it's considered outpatient status. And so thereby we cannot accept like inpatient ED transfers, so we can accept ED to ED transfers, but not patients who are already at inpatient status to transfer. Whereas CCRU and Flex ICU, because they're inpatient status, they can accept inpatient ICU to ICU transfers and such, and also ED to ICU transfers. So we have been able to essentially downgrade. So we have a whole list of consult criteria for EC3, which I did not show. But one is essentially, requiring critical care needs, and then there's also a clause about availability of beds within greater than 2 hours. And then also during high volume, when we have multiple resuscitation patients, we would take them directly sometimes. And so we've been able to downgrade about 60% of, the 20,000 patients that we care for during the past 10 years. And the length of stay for these patients, so in terms of like the patient who were able to downgrade, we end up, their EC3 length of stay is about anywhere from half a day to greater than like 12 to 24 hours on average. Sometimes though, it's essentially a pop-out valve for the entire health system's capacity, as you can imagine. So we've had days where we actually care for EC3 patients for days at a time, but on average, the downgrade patients, we have them for about half a day to a day. They ultimately can still end up getting boarded in EC3, unfortunately, because if they have nowhere else to go in the hospital, then we face the same issue as any other ICUs in the hospital. And then for the patients who continue to require ICU care, so these are the sickest of the sick, their length of stay in EC3 has been about 12 hours or so, 8 to 12 hours, basically. But again, it depends on whether or not we have beds upstairs. So if the medical ICU, if they're completely full, then we could end up holding on to these patients for longer than that. So
Thanks.
okay, any other questions? Thank you, Neha. It's great to see you. Thank you for stopping by.
Oh, great to see you too. Really fantastic work. And the fact that you covered everything from triage all the way up to PICS and burnout, that resonates quite deeply with me. A lot of our work for neuro emergencies management and transfers, that NEMAT program, then our critical care recovery clinic, and all the trouble that we all need to go through from a bureaucratic perspective to ensure the success of these kinds of programs. I mean, it's a true labor of love and fantastic success stories from your end, and all the great collaborations that you've been able to establish, nationwide. It's really inspiring to see. Thank you, Cindy.
Thank you.
Cindy,
right, well,
it's 2 o'clock, so I'm gonna let you go. Thank you again so much for joining. It was great to catch up.
Pleasure. And tell Ben I say hi.
I will. Hopefully we'll get to catch up at SCCM or ASAP one of these days.
For sure. All right,
Okay.
great. Thank you, guys.
Bye.